Mahendra, Mahendra, Mahendra,
Yes, sir.
Mahendra, should we start? So my introduction will get over, and at 3:30 we will begin the session.
Okay, that way we have to do. Okay, no problem. We will start now.
We have started
So,
now.
okay, yeah, fine. Welcome, dear participants on the webinar. Today is the Saturday, on 9th of May to 2020 during lockdown period across the country. With the declaration of green, orange, and red zone, the partial functioning has begun. At the same time, the cases are increasing, and still through the virtual media, we are enhancing our knowledge, and at the same time, with this knowledge, the patient management, which is most important part. Today we have the topic approach to pediatric portal hypertension. As we have discussed on the two forum on the which Penicia Biotech is sponsoring, the important is Wilson's disease in pediatric patient and vaccinations. We have observed that the most important faculty and the specialty which has impacted is pediatric patient. When we are talking about the pediatric, it is the team approach where the patient self, parents, the primary care physician, the specialist, and then the super specialist or the tertiary care center, which is having the special team to manage the liver and associated conditions. When it comes to the pediatric, it is a pediatrician who is experts into the liver conditions is most important. Hence, for today's topic on pediatric portal hypertension, we have Dr. Rajiv Khanna, who is a MD pediatric and a fellow at Pediatric Hepatology, King's College Hospital, London. He is having the affiliations as a additional professor at Department of Pediatric Hepatology, Institute of Liver and Biliary Sciences, New Delhi. He is having the enormous research in pediatric hepatology, most important including neonatal cholestasis, gut liver axis, pediatric portal hypertension, and pediatric acute liver failure. For this, we have Dr. Vikrant Sood, who will moderate and interact and take up the questions from the audience, which are reflecting to us at the end of the session. Dr. Vikrant Sood is also from the same institute. He is a DM pediatric hepatology, and in the same department, he is having working as an assistant professor. Dr. Vikrant is from the prestigious institute, New Delhi, and he also his academic interest reflects with the more than 50 publications into the national and international journal. So I request Dr. Rajiv Khanna to initiate the today's session on approach to pediatric portal hypertension.
Good afternoon, everyone, and thanks, Dr. Kunal, for this introduction. And I would like to thank Penicia Biotech for organizing these webinars and spreading the message from the pediatric hepatology team. So today I'm going to talk on this approach to pediatric portal hypertension. Yeah, so I will give my talk by describing various case scenarios, briefly about pathophysiology and when to suspect cirrhotic versus non-cirrhotic portal hypertension and complications basically dealing with varices and how to manage them and what is new. So to begin with, so we should know what are the various presentations of childhood chronic liver disease. So the first one is hepatocellular chronic liver diseases, where we have elevation of transaminases, deranged albumin, INR, ascites, and encephalopathy, everything part of decomposition. So here the commonest diseases which we deal with are Wilson disease and autoimmune liver disease. The second commonest presentation is cholestatic liver diseases, where we have elevated alkaline phosphatase and or GGT with fat-soluble vitamin deficiencies, jaundice, pruritus may be there, acolic stools. Some of these children present with cholangitis and have significant growth failure. And the commonest etiologies here are biliary atresia, PFICs, Alagille syndrome, and sclerosing cholangitis. So the third one, which we are going to discuss today here, are the portal hypertensive presentations of liver diseases in children. So this group of disorders present with splenomegaly, Hyperspleen is because of the enlarged spleen, and the liver synthetic functions are relatively preserved, and jaundice is most of the time absent. And again, there is growth failure because of big spleen. And the common prototype disorders here are extrahepatic portal venous obstruction, and rarely we also see non-cirrhotic portal fibrosis, congenital hepatic fibrosis, and Budd-Chiari syndrome. The last one is organomegaly, when we have hepatomegaly or splenohepatomegaly, where the enzymes are elevated, synthetic functions are preserved, and here the typical disorders are glycogen storage disorders, lipid storage, and lysosomal storage disorders like Gaucher's or Niemann-Pick disease. So beginning with the first case scenario, so this was a 2.5-month-old baby who presented, who was term appropriate for gestational age, with a birth weight of 3.2 kg, exclusively breastfed, and subsequently within first week of life he presented with fever and lethargy and was diagnosed as late onset neonatal sepsis, and with a positive culture, methicillin resistant staph, and subsequently he had on ultrasound multiple hypoechoic space occupying lesions in the liver. And so the diagnosis was suggestive of liver abscess, and subsequently at day 25 he was detected to have portal vein thrombosis. Subsequently, when he presented at 2.5 months of age, he was asymptomatic, he was gaining weight, and it was around 5.5 kg. There was no ascites, jaundice, bleeds, or irritability. So on examination, there was no pylorictus, no stigmata of chronic liver disease, but on examination, the liver was around 2 centimeters and spleen was 2 centimeters below costal margin. And ultrasound showed that portal vein was on Doppler. The portal vein was replaced by multiple collaterals, which we also call as cavernoma. So this was a typical portal vein thrombosis secondary to an infective insult in the neonatal period, which was multiple liver abscess. So to summarize, so this was neonatal sepsis resolved pyogenic liver abscess and now portal vein thrombosis. So next, going to the case scenario 2. So this was a boy who presented at 7 years, 8 years, and then 10 years with recurrent massive upper GI bleed and hematemesis and melena associated with postural symptoms, and all of these episodes required blood transfusion. So in the background, there was no history of umbilical sepsis or catheterization, no liver abscess, abdominal surgery or trauma, no pancreatitis, and no family history of prothrombotic states. And again, in any of these presentations, there was no jaundice, ascites, encephalopathy, or coagulopathy. So subsequently, he underwent upper GI sessions which showed large varices and which were treated with endoscopic variceal ligation. On examination, he was pale without any jaundice, but his growth centiles were low. There were no stigmata of chronic liver disease, but on examination, there was massive spleen around 13 centimeter below costal margin. So to summarize, so this was a boy, 10-year-old, who presented with splenomegaly and recurrent massive upper gastrointestinal bleed, and he had, and there were no apparent predisposing factors for the variceal bleed or any prothrombotic states in the family. So we can have the summary like this: the massive upper GI bleed, recurrent episodes, massive splenomegaly, and no stigmata of chronic liver disease. So just looking up these three things together, we can just make out that this is a typical variceal bleed. So this is a child with portal hypertension, and as there were no stigmata of chronic liver disease, so this is a typical case of non-cirrhotic portal hypertension. Most likely, what in our setup which we see is extrahepatic portal venous obstruction. So next case is a girl, adolescent, 16-year-old, who presented with at 11 years of age with progressive increase in the left upper quadrant swelling, discomfort, and there was intermittent dragging sensation. This was followed by malaise and some weakness, and also she was undernourished. So there was history of poor weight and height gain. There were no history of any jaundice, bleeds, so there was no decomposition at all. There were no histories to suggest any autoimmune conditions like rash, joint pains, and nothing to suggest any neurological deterioration which may point towards Wilson. So there were nothing like this. There were no cholestatic features in the form of pruritus. So there were no fever, bone pains, or any neurological manifestations. So there was no past history of jaundice, no family history of any liver disease or recurrent abortions. So in development was normal as per peers, and she had oligomenorrhea. So on history, so this adolescent had had history of left upper quadrant mass, which was possibly a big spleen, prolonged course, and she had growth failure on examination. Again, she was found to be undernourished, and there was some pallor. There were no stigmata of chronic liver disease, and per abdomen examination, liver was 2 centimeters below costal margin, and spleen was massively enlarged, crossing the umbilicus around 22 centimeters below costal margin. Rest of the other systems were normal. So her diagnosis was, so this was an adolescent with progressive increase in the spleen size, anectric, without any stigmata of chronic liver disease, growth failure, and mild hepatomegaly. So in her case, we can approach the diagnosis like this. So this was the differentials of portal hypertension, storage, or hematological work cap. So portal hypertension was kept as top because the spleen was massive, and there were certain other features on subsequent imaging. So non-cirrhotic versus cirrhotic, because there were no stigmata of chronic liver disease. So in the non-cirrhotic group, non-cirrhotic portal fibrosis, extrahepatic portal venous obstruction, or congenital hepatic fibrosis were kept. Then cirrhotic. Then in the storage disorders, there were nothing to suggest all those storage disorders. Like there were no neurological features, no lung disease, and no bone pains or fractures to suggest any Gaucher's or Niemann-Pick type B. And also, if we consider infiltrative or hematological conditions or hemolytic state, there were no history to suggest any frequent blood transfusions, no fever, bleeds, or any recurrent infections to suggest hematological states. So on investigations, she was found to have just mild increase in the bilirubin 1.35 and mild increase in transaminases. But if we can see here, the synthetic functions, the INR was normal 1.3 and albumin was preserved 4.1. So yeah, and other tests revealed low cell lines, TLC 2400, platelets 20,000. So in the presence of a big spleen, if the platelets are less than 1 lakh, TLC is less than 4,000, and hemoglobin is less than 10. So there was pancytopenia with massive splenomegaly. So this is a typical hypersplenism presentation. Although bone marrow was not done here, so but if we do bone marrow in these children, so that actually typically reveals that these lines are hyperplastic. So these cell lines, which in the periphery are low, so these cell lines are would be hyperplastic. So in the CLT workup, everything else was negative. So Wilson, autoimmune, Budd-Chiari, hepatitis B, hepatitis C, all were out. So on ultrasound, we looked for any other vascular cause, like portal vein obstruction was not there, portal vein was patent, hepatic vein outflow tract obstruction, that is Budd-Chiari syndrome, so they were all patent, so that was not the thing. Liver was small and shrunken, and there were numerous collaterals present. So this we can see on the ultrasound. And CT also confirmed the same finding. There was massive splenomegaly, and there were multiple collaterals. So these things can be seen in this picture. Subsequently, she was taken up for liver biopsy, and as we can see here, there was fibrosis. There was just mild portal and periportal fibrosis. Otherwise, the liver histology was not actually contributory. So this was a typical case of a non-cirrhotic portal fibrosis. So with splenomegaly, portal hypertension, she was found to have varices, and she was started on variceal bending sessions. She had hypersplenism, so her diagnosis of non-cirrhotic portal fibrosis was made. So the next and the last scenario is a 19 months old girl who presented at 16 months of age with progressive increase in the abdominal distension, and subsequently she required multiple large volume paracentesis. So she had progressive ascites requiring repeated taps, and she had subsequently she had progressive weight loss. So, but there was no history of any recurrent fever, no jaundice or any other decomposition in the form of variceal bleed or hepatic encephalopathy. There were no recurrent fever or cough, no history of any pain in the abdomen, no history of any renal symptoms, no history of any cardiac symptoms. Birth histories were uneventful, and the family history, there was no consanguinity, no history of any liver or autoimmune disease, and no history of anything to suggest any prothrombotic states. So on examination, she was found to be undernourished, and she was tachycardic, tachypneic because of massive ascites. And if we can see here, the back veins were prominent. So she had prominent abdominal as well as back veins. So this is again a pointer towards one of the vascular disease of the liver, which is Budd-Chiari syndrome. And also another thing was absent hepatojugular reflex. So hepatojugular reflex normally should be present when we press when we press the abdomen just beneath the liver and press it for at least hold it for 30 seconds, so then there should be a rise in the jugular venous pressure. So this reflex is actually absent when there is hepatic venous outflow tract obstruction, when the pressure from the abdomen cannot be transmitted into the IJV. So on examination, she had massive ascites, abdomen was grossly distended, so organomegaly could not be made up, and the rest of the systems were normal. So she had refractory ascites. So the diagnosis, the possibilities which were kept were hepatic venous outflow tract obstruction in view of the finding which I told you that she had prominent back veins, and also she had absent hepatojugular reflex, but also the differentials of malignancy and tuberculosis were kept. Subsequently, she was evaluated and she was found to have normal ALT and normal INR. So that indicates that the liver synthetic functions were relatively preserved. Albumin was low because of underlying malnutrition state. Ultrasound showed hepatomegaly, and the Doppler confirmed that the 3 hepatic veins and the IVC were all blocked. So ascitic fluid analysis was done, which showed a SAG value. SAG means the difference between the serum albumin and the ascitic fluid albumin. So if this value is more than 1.1, that indicates that this is portal hypertensive ascites. So this value was 1.2 in her. So that indicates the cause of ascites is actually portal hypertension. So if we look up the exudative causes of portal hypertension like tuberculosis or malignancy, then the SAG value comes out to be low. So the prothrombotic profile and echocardiogram were all normal. So this is the CT picture of this girl where we can see that IVC was chinked and the hepatic veins were not visible. And also there was a patchy enhancement of the liver, which is also a characteristic feature of Budd-Chiari syndrome. There was more contrast in the center of the liver, and in the periphery it was less. So we have discussed here 4 different scenarios of portal hypertension. So the first 3 were related mainly to the massive spleen. One of the scenario was related to variceal bleed, and one case we discussed of a neonate who had eventful perinatal course, and subsequently his portal vein got blocked. And the last one we discussed about again a portal hypertensive presentation where the presentation was more with ascites, and the synthetic functions in all of them were relatively well preserved. So briefly discussing about the pathophysiology of portal hypertension, the liver receives its blood supply 75% from the portal vein and 25% from the hepatic artery. So this diagram shows how the portal vein is formed. The portal vein is formed from the splenic vein and superior-mesenteric vein, and this goes into the liver, divides, and so on the right hand side we can see the inflow vascular supply of the liver, which is by the portal vein, and on the left hand side we can see the exit vascular supply of the liver, so which is by the 3 hepatic veins. So the portal vein divides into various portal venules, which drains the various sinusoids into the liver acini, and from the sinusoid the blood goes into the central veins, then hepatic venules, and the 3 hepatic veins which drain into the inferior vena cava. So this is the microscopic diagram of the liver, where we can see that in the SNS from the portal tracts there are 3 structures: portal venule, hepatic arteriole, and bile ductule. Whereas in the center of the SNS is the central venule, which form the ultimately the hepatic venules and the hepatic vein. So the blood supply within the SNS is from the portal tract, is from the portal vein to the central vein, whereas the bile flow is from the central vein towards the portal venule. So how do we define portal hypertension? Portal hypertension is defined as when the pressure gradient is between the portal vein and the inferior vena cava is more than 5 millimeter of mercury, and this pressure gradient. So going back to our physics teachings based on the Ohm's law, so the pressure depends on 2 things. The pressure depends on flow as well as the resistance. So whenever the flow is high, that is hyperdynamic. When the flow is actually hyperdynamic, so that also leads to high increase in the portal pressure. And also when there is more of resistance, that is liver fibrosis, so then also the portal venous pressure increases. So when the liver is fibrotic and progresses towards cirrhosis, when in the right hand side we can see the cirrhotic liver, when there is deposition of collagen in the space of Disse, activation of the hepatic stellate cells, and the defenestration of sinusoids. So everything is, so there is sinusoidal obstruction. So this is the sinusoidal cause of portal hypertension. So because of the increased resistance, again there is increase in the pressure leading to portal hypertension. So going again back to the anatomy of the portal hypertension. So what happens when there is cirrhotic liver? So with presence of cirrhosis, there is development of collaterals because the backflow increases. So there is development of more and more of collaterals. There is increased venous return back to the heart, leading to increased cardiac output and increased heart rate, and increase in the splanchnic arteriolar vasodilatation, just to compromise the vascular supply of the vascular supply from the portal vein side. So there is increased splanchnic arteriolar vasodilatation, and because there is too much of splanchnic vasodilatation, there is decreased systemic arterial underfilling. There is underfilling of the systemic vascular system, leading to increased sympathetic activation, leading to increased renin, angiotensin, aldosterone system, so thus leading to the renal complications and development of ascites in a cirrhotic cause of portal hypertension. So there are two processes which go on simultaneously. There is increased flow, which is caused by the hyperdynamic circulation because of the increased systemic as well as splanchnic vasodilators. And the commonest one of this is nitric oxide, and the other ones are like COX and heme oxygenase and LPS agonists. And also there is more of angiogenesis and development of collaterals. And the other process which also goes within the liver is increase in the intrahepatic resistance, which is caused by fibrosis and also by various intrahepatic vasoconstrictors. The common ones of these are angiotensin 2 and endothelin 1. And also the endothelial cells get transformed to have contractile as well as the fibrogenic properties to form myofibroblasts. So thus, this is the summary: cirrhosis, portal hypertension, development of collaterals, arterial vasodilatation, and hyperdynamic circulatory state, leading to decrease in the mean arterial pressure, decrease in the systemic vascular resistance, increased cardiac output, development of varices and ascites. So also there is role of gut dysbiosis in the development of portal hypertension. There is, with portal hypertension, as it progresses, there is more of epithelial barrier disruption leading to bacterial overgrowth, dysbiosis, and also there is imbalance in the various bile acids and also immune dysfunction. So everything leads to development of portal hypertension. So one of the mechanisms here has been shown that because of the bacterial overgrowth, translocation, and inflammation, there is decrease in the intrahepatic bile acid circulation, increase endotoxins, leading to decrease in the farnesylate X receptor. So decrease FXR activation leads to further development of portal hypertension. And this has been shown clinically that how gut microbiota relates to portal hypertension. So in this study, they have shown that there are two different kinds of bacteria within the within the gut. So as we go from the healthy state to compensated to decompensated to the complications of chronic liver disease, the proportion of the good bacteria progressively decrease. And this ratio of good versus bad bacteria, so there is negative correlation of this ratio with the endotoxin levels in the blood of these patients with cirrhosis. Another thing is angiogenesis, that is development of collaterals, and this is mediated by various factors, and some of these are like vascular endothelial growth factors and placental growth factors. So to classify the various causes of portal hypertension, so the first group is pre-hepatic causes of portal hypertension, that is before the portal vein enters into the liver. So so next one is hepatic causes of portal hypertension, and these can be further classified as pre-sinusoidal, sinusoidal, and post-sinusoidal. And the last one is post-hepatic causes of portal hypertension. So the same causes can be seen here also. The extrahepatic or pre-hepatic causes, the typical causes. The typical etiology is extrahepatic portal venous obstruction. Next is pre-sinusoidal causes. The common two pediatric etiologies are congenital hepatic fibrosis and non-cirrhotic portal fibrosis. Then the sinusoidal causes, which include all the causes of cirrhosis. Then post-sinusoidal is a veno-occlusive disease developing in the setting of bone marrow transplant. And the last one is post-hepatic cause of portal hypertension, which means outside the liver, when the hepatic veins or the IVC get obstructed, that is Budd-Chiari syndrome, and also beyond IVC, that is when there is cardiac involvement like constrictive pericarditis. So if we see a child with upper gastrointestinal bleed with splenomegaly, or if a child is already known to have a chronic liver disease or is having a stigmata of chronic liver disease with splenomegaly, or if we find varices on upper GI endoscopy, or if there is a splenomegaly along with certain markers like if the platelets are low, platelets are less than 1 lakh, so So all of these things indicate that the patient is having portal hypertension. So if the patient is having portal hypertension, then we have to go to look for whether there is any evidence of chronic liver disease, and whether and if the bleed has already happened, so whether this was a poorly tolerated bleed or well tolerated bleed. So poor tolerance means whether the patient has decompensated after that bleeding episode, has developed ascites, encephalopathy, jaundice, or coagulopathy. So if the CLD is present, or if this is a poorly tolerated bleed, so if the answer is yes, so then this is a cirrhotic cause of portal hypertension. The common causes of cirrhotic portal hypertension in the pediatric age group are biliary atresia, PFIC, autoimmune hepatitis, Wilson, or some of the metabolic liver conditions. And if the answer to these two questions are no, so then this is non-cirrhotic portal hypertension. So then we have to look for on ultrasound Doppler whether the portal vein is patent or not. If the portal vein is patent, so then we have two etiologies. One is congenital hepatic fibrosis, other one is non-cirrhotic portal fibrosis. And if the portal vein is not seen, it is replaced by collaterals, which is called cavernoma. So then this is a typical extrahepatic portal venous obstruction. So how to differentiate cirrhotic from non-cirrhotic portal hypertension? Some of these things we already discussed, but in a non-cirrhotic cause, there will be absence of jaundice, there will be no decomposition, veins, dilated veins, these things will not be present. Whereas in the cirrhotic causes, there will be jaundice, liver will be shrunken, irregular, firm, there will be prominent veins, and the growth failure will be present in both the etiologies, whether cirrhotic or non-cirrhotic. So we should always remember to look for the stigmata of chronic liver disease in the form of pulmonary edema, clubbing, facial telangiectasia, spider nevi, gynecomastia, and on per abdomen examination, we should look for prominence of veins, direction of flow, whether they are away from the umbilicus in the form of a caput medici, and feel of the liver, whether it is soft, firm, or hard. Firm and hard liver indicates cirrhosis. And size of the liver, how many centimeters below costal margin, how many centimeters below Ziphi, whether it is unilobar involvement or a bilobar enlargement of the liver. In some of the diseases, and particularly in cirrhosis and congenital hepatic fibrosis, the left lobe is more enlarged. Then surface of the liver, whether it is smooth or nodular. Then margins of the liver, whether they are regular or irregular. So irregular nodular liver are pointers towards cirrhosis. Then splenomegaly. Splenomegaly is always measured in the direction towards the umbilicus. Then presence of free fluid on shifting dullness and fluid thrill. So we should always make a habit to make this hexagon in our case sheets and to mark the size of the liver and also the spleen and presence of free fluid, and if veins are present. So we should mention the veins and the direction of flow in these veins. So this table mentions the differences between the common etiologies of portal hypertension in children. So extrahepatic portal vein obstruction, non-cirrhotic portal fibrosis, congenital hepatic fibrosis, and cirrhosis. So extrahepatic EHPBO presents in first decade, and the same is with with CHF. Cirrhotic etiologies most often decompensate after a varicose bleed episode. So they may have ascites after the bleeding, and also they may have history of jaundice and encephalopathy, and the liver is usually shrunken, LFTs are deranged. Splenomegaly is usually massive in EHPBO and CPF. Histology, congenital hepatic fibrosis may indicate a typical histology like white fibrous bands or dilated bile ducts, or there may be sometimes a ductal plate malformation like picture. Whereas in cirrhosis, the things will be evident on the histology. Ultrasound Doppler will show a cavernoma in EHPBO, whereas in cirrhosis there will be dilated portal vein with flow reversal on the Doppler. In non-cirrhotic portal fibrosis, again the portal vein will be dilated with a typical tapering pattern, which is called with a tree appearance. In congenital hepatic fibrosis, we may be able to find renal cysts on ultrasound because CHF is known to be associated with autosomal recessive polycystic kidney disease. HVPG, which is hepatic venous pressure gradient, can differentiate between the non-cirrhotic and the cirrhotic causes of portal hypertension. So these are the two etiologies which are shown here. Both are vascular, EHPBO as well as NCPF. In EHPBO, there is everything starts from a thrombus involving the main portal vein, whereas in NCPF, the things start from the small portal venules. So this is a busy slide, but here we can see that if there is portal hypertension in the absence of features of chronic liver disease, so when there is clinical suspicion of non-cirrhotic portal hypertension, so then we should look for certain things in the history. Like for EHPV, we should ask umbilical vein catheterization, umbilical sepsis, history of liver abscess, appendicitis or pancreatitis or any trauma. History of any prothrombotic state in the child or in the family, and other things are like for congenital hepatic fibrosis, we should remember certain syndromes which are associated with congenital hepatic fibrosis, and these ones are Ivermark syndrome, Dandy-Walker syndrome, Joubert syndrome, Meckel-Gruber syndrome, Bardet-Biedl syndrome, and Gion syndrome. Then certain disorders are related to non-cirrhotic portal fibrosis like HIV or secondary or primary or secondary other immunodeficiencies. Then medications and toxins like arsenic and azathioprine, which can cause non-cirrhotic portal fibrosis. Then certain immunological conditions like SLE or scleroderma and prothrombotic states. And so these are all conditions which can lead to development of non-cirrhotic portal fibrosis. In the lower part of this slide, we can see that what is the natural history of these disorders. So initially, to begin with, there is just splenomegaly. Subsequently, children may present with variceal bleed. They have features suggesting hypersplenism. They have growth failure, and later part of the life in adolescence or late adult, they may present with portal biliopathy. And by 30s or 40s, they may have parenchymal extinction with features similar like in cirrhosis, similar to decomposition. So if we look up etiology of portal hypertension in children, so from the Western data, the commonest etiology are cirrhotic causes, biliary atresia, autoimmune hepatitis, and in their set of antitrypsin deficiency. So alpha-1 deficiency is not seen in Indian children. From the eastern side, means from India, the commonest etiology still of portal hypertension is EHPVO as reported in the literature, followed by intrahepatic causes of cirrhosis and NCPF, Budd-Chiari syndrome, and congenital hepatic fibrosis. But there are differences among centers because of the referral bias. Still, in our setup, we see cirrhotic cause of portal hypertension to be more common, and the commonest cause in our setup is biliary atresia and other cirrhotic causes like autoimmune hepatitis. So variceal bleed. So what is the risk of variceal bleed in cirrhotics versus non-cirrhotics? So there is almost 6 times more risk of bleeding in EHPVO in comparison to the cirrhotics, but the mortality rate in cirrhotics after a variceal bleed is around 30%. To identify portal hypertension by using various non-invasive markers. So one indicator and the most easy indicator is the platelet counts. So if the platelet counts are less than 100, and if we are suspecting a child is having portal hypertension, so that may indicate that he is having he may be having varices or other complications. So this is an index which is used in adults as well as in the pediatric literature. So this is AST times upper limit of normal and divided by platelet count. So this index, so if the value of this index is more than 1 or more than 1.5, that may indicate that significant fibrosis has already developed, and more than 1.5 indicate that there should be cirrhosis. So this is another indicator which has been used in the pediatric liver disorder. This is clinical prediction rule using 3 parameters: splenic Z-score on ultrasound and albumin. So based on these, so if the CPR value, this clinical prediction rule value, is less than 115, or if the platelet count is less than 15, so we can, so if this is there, so then the endoscopy may be indicated. But if any of these is more than 115, so the endoscopy can be deferred for screening for varices. So another score is King's variceal prediction score based on albumin and splenic Z-score. So the children were predominantly cirrhotics and biliary atresia. So that's why this index takes into account albumin and splenic Z-score. And this also has a good sensitivity and specificity. So next is a non-invasive indicator is transient elastography or fibroscan, so which is like an ultrasound probe, which is where the vibrations are introduced on the surface of the skin, and these vibrations are of mild amplitude and low frequency, induced by a transducer, and wave is transmitted into the liver, and the basis is that the wave transmits faster in a stiff liver as compared to a soft liver, and this value is expressed in terms of kilopascal. So higher the value, the more stiff is the liver, and more chances of the liver-related complications. So the principle, is shown in this cartoon. So here is the transducer probe, which is transmitted into the liver, and the value is obtained in this form. So this is the picture showing the FibroScan in a child. It hardly takes around 3 to 5 minutes. So 10 values are taken and a median of these values is taken, but the condition is that the success rate should be more than 60% and the interquartile range should be less than 30% of the median value. So as the values increases, there are more chances of clinically significant hypertension, development of varices, large varices, and risk of variceal bleed, and also development of hepatocellular carcinoma in adults. So in pediatric age group also this has been used, and in biliary atresia children it has been shown that when the value is above 9.7 or 10, so then it has then there are more chances that the patient will be having varices. Another thing is, so up till now we have been doing the liver fibroscan. So another thing is splenic fibroscan. So splenic fibroscan studies have shown that it directly reflects the severity and the degree of the portal hypertension. So it has been shown that that there are differences whether the varices are present clinically significant or not in the pediatric age group. So the splenic stiffness can differentiate these patients. A cutoff of around 42.8 has been proposed to predict development of variceal bleed in children with extrahepatic portal venous obstruction. Then there are ultrasound markers to look for portal hypertension. So
Dr. Vikrant, you would need to share your slides in case you're looking for sharing your slides.
No, I'm not supposed to share any slides. I'm not seeing Dr. Rajiv's slides. Did we get disconnected from Dr. Rajiv?
Don't disconnect, continue it. It may get restart.
No. Did we get disconnected from Dr. Rajiv?
Yeah, online it got disconnected. It is showing that the live event will continue in a moment.
Okay.
It is showing some technical error. Are you going through the questions on the panel?
Yeah.
Okay. Anil, the telecast is temporarily showing.
While Dr. Rajiv is reconnecting, so can we take up the questions that are being asked in the Q&A, and Dr. Vikrant can probably
Yes.
answer the questions?
Yeah, sure. Dr. Vikrant, you can continue with the questions and answer.
Do you want me to answer? Or should we wait for Dr. Rajiv to answer?
Ashish, will it take time? Yeah, Vikrant, Dr. Vikrant, you take question and answer.
Okay.
You are live.
Yeah. So, very good afternoon to all. While we wait for Dr. Rajiv's slide to come back again, I think we can start.
को देख पा रहे हैं डॉक्टर विक्रांत को? ठीक है.
Yeah, Dr. Vikrant, you continue. You are live.
So,
Yes,
first
please.
question is, what is your experience of EHPVO patients landing to chronic liver disease? It's a rare phenomenon which I don't think we have seen in pediatric patients because it's not a very well-defined phenomenon. But adult series, if you see, and we have seen in adult patients here, EHPVO patients who have been followed up for decades and decades altogether, say in the older age, 4th, 5th or 6th decade, they undergo a phenomenon which is known as parenchymal extinction. But this phenomenon, I don't think has ever been described in a pediatric population less than 18 years of age. So personally, we haven't seen in a patient pediatric patient of EHPVO going into chronic liver disease, but yes, adult literature is there, though it is scarce, and these patients have been transplanted, and we have seen in their adult explant tissues that they have a preserved parenchyma which has gone into extinction. And the volume of hepatocytes which is too less, they develop ascites and all those complications which a cirrhotic patient would develop. And they would develop this parenchymal extinction, and then they would require liver transplant in the future. But it's a rare phenomenon even in adults. I don't think I can give you an exact percentage, but it's a phenomenon which is not seen in children. At least we haven't seen it, and even in adults, it's a rare phenomenon. So second question, I can see, I don't see the name of the person who has asked this question. It is like, do you routinely do fibroscan for monitoring purpose and baseline liver biopsy? I'm not sure if they're asking for EHPVO or cirrhotic patients or non-cirrhotic portal hypertension patients. I'm not sure why they're asking it, but preferably there is no need of doing a fibroscan for EHPVO patients, especially when you know that there is no parenchymal injury as such. But in cases like non-cirrhotic portal fibrosis or cirrhotic patients, yes, we usually do recommend doing a fibroscan at the baseline because it helps us monitor, because fibroscan is not a very expensive thing. It's now routinely available across all hepatology and gastroenterology centers, and it is very easy to do it as a non-invasive marker of underlying liver fibrosis, because you can follow it up every 6 monthly or yearly, and then you can make out how your treatments are working. Suppose you're giving it for a cirrhotic patient like Wilson's or autoimmune, you would see that though there is no definite indication of doing it in every patient, but if you are doing it, you would definitely see a patient who is being treated for a treatable etiology like Wilson's or autoimmune. Their fibroscan would start going down along with improvement in all their liver parameters. So for diagnostic purpose, you may or may not do fibroscan in all purpose, but for monitoring, especially if you are following up these patients who are being treated or who are being managed, it's a good non-invasive methods of monitoring. And baseline liver biopsy, not for EHPVO patients, definitely not, but non-cirrhotic portal fibrosis, because it's a histological diagnosis, and cirrhotic Yes, we would prefer doing a baseline liver biopsy. And if we go to the next question, let me just. So do you ask for coagulation screen for hypercoagulability in the absence of umbilical catheterization or neonatal sepsis? And how to balance between anticoagulation for hypercoagulability and risk of massive bleed with anticoagulant? So I think they are asking about the coagulation screening for patients with EHPVO. I'm assuming it. So EHPVO, let me be clear about this thing that there is still no, it's mentioned in books, but role of umbilical catheterization in the neonatal period and its relation to portal vein thrombosis and leading to EHPVO is still not confirmed. If you look at the literature, there are studies from India, they have proven that patients who developed, say, portal vein thrombosis after they have been catheterized, most of them would resolve. There is no definite evidence as of now in the literature. Previously, we used to believe that patients who used to undergo umbilical catheterization, they are the ones who are going to develop portal vein thrombosis. But there are studies from India, from Professor Sarin's work initially that was done in GB Pant and MAMC. They have shown that patients who had undergone umbilical catheterization and later developed portal vein thrombosis, almost none of them developed EHPVO. So there is still no definite evidence which links umbilical catheterization to EHPVO. So whether do we need to do a coagulation screen in all patients of EHPVO? We as a academic institute, we do it, especially when we do not have any other incriminating factor. But I don't think there is a very definite correlation between what you get in your hypercoagulable screen or EHPVO, but a significant percentage of our group we have found some of those hypercoagulable states we have found in some of our cases. But I would not say that it is mandatory, because practically it does not change your management unless you are finding those genetic factors, especially in a homozygous form. And and the second part is how to balance between anticoagulation for hypercoagulability and risk of massive bleed with anticoagulant. Personally, we do not anticoagulate EHPVO patients because there is no need for them. Whether you are asking about whether they need a anticoagulation, especially after they undergo a shunt surgery, not for lifelong. We give it lifelong only when we have a confirmed genetic basis for hypercoagulation that we'll find in, say, factor 5 mutation or other mutations. We give it for a short period, say a couple of 6 months to 1 year or even 2 years after they undergo a shunt surgery, but not beyond that. And risk of massive bleed with anticoagulant is very, I don't think it's very common. I personally haven't seen patients bleeding when you're closely monitoring them whenever you are using anticoagulant, because I'm not sure it's not a common phenomenon. If you are monitoring them well and you are not exceeding the doses of anticoagulant as per the recommended literature, there is very less risk of them bleeding because of anticoagulant. So let me tell you, risk of massive bleed with anticoagulation whenever. So let me put in another word. A patient of EHPVO who has underwent a shunt surgery, and say you are giving him anticoagulant. So the risk of his bleed, him bleeding because of anticoagulation is less likely, but more likely is that either his shunt has blocked and he has developed those varices again for which he was treated initially. So risk of bleeding with anticoagulation is very less compared to the risk of his primary pathology coming up again. That's what we believe. Another question is role of probiotics to tackle dysbiosis in cirrhosis later portal hypertension. It's still a new field. We normally don't use it. we don't use probiotics to tackle dysbiosis at all. It's still an experimental field. People are in adult population, people are resorting to say doing fecal microbiota transplantation, which is a more advanced form of tackling dysbiosis in cirrhosis-related portal hypertension, but they have used it mostly in alcoholic hepatitis and all that disorders. In pediatric population, it has been this fecal microbiota transplantation has been used in inflammatory bowel diseases and other C. difficile related colitis and all those things. But but probiotics per se, I don't think, because the kind of dosages that you would require would be huge to manage the dysbiosis that is there in your intestinal transplant. You would require lot and lot of dosages to just change the microbiota that your intestine is carrying. So I don't think personally at present there is any use, practical use of giving probiotics to your patients who are having cirrhosis-related portal hypertension. But you never know; these things may come up later in the future. Another question is, I'll be wait for Dr. Rajiv to join back. Why some cirrhotics develop ascites without varices and or varices without ascites? Okay. You'll see when you look at the timeline of a patient who has developed cirrhosis and then develops portal hypertension and then decompensates. You would expect a patient to first develop some liver resistance or hyperdynamic circulation. Then you expect the portal hypertension to set in. Portal hypertension to set in means that they would develop collaterals, and if the pressures go high, as Dr. Raji has shown your Ohm's law, then the varices would develop. So it is less likely that a patient who has to develop ascites without any varices. It does not mean that when you are putting up and it sometimes happens when you do an upper GI endoscopy, you may not be able to see varices, especially if the person is not very careful. There would be small varices, there would be other signs of portal hypertension. They may develop varices in all other sites, not just at the GE junction or the stomach. But definitely a patient who has developed ascites because of cirrhosis, he would definitely would have collaterals on abdominal imaging. Whether or not you're able to see the more advanced version, that is the varices or not, that is still, we may or may not see them varices, especially they have acutely bled, because sometimes patients who have developed acute variceal bleeding, their varices may collapse and you may not be able to see those varices at that time. But pathophysiologically, there is no patient who would have ascites without abdominal portal hypertension collateral circulation. And so let me check. Another question is, I think it's asked by Dr. Pratik. APRI works in EHPVO also. Personally, I'm not a big fan of using these indices, but APRI, if you can make out, APRI is the ratio of AST, that is aspartate aminotransferase levels, divided by the platelet count. So AST, if you think in that manner, that AST levels are usually higher in cirrhotic patients because of the longer half-life that they develop in cirrhotic patients. So personally, I won't use APRI for EHPVO patients in which you do not find any parenchymal abnormality and do not think that your AST levels would be higher in EHPVO. But it's better that you use other modalities, like other indices, like Dr. Rajiv mentioned. That includes other clinical prediction rule and King's variable prediction rule, but these rules also have been predominantly studied in the cirrhotic groups like biliary atresia. So personally, I'm not very in favor of using indices, especially for the non-cirrhotic patients like EHPVO. Dr. Pratik also asks that all indices work same in adult also and in any cause of portal hypertension. Okay, This work predominantly APRI and all those work have been predominantly done in cirrhotic patients. There are studies about non-cirrhotic populations also. So predominantly, I would say that cutoffs are different, but still they have been documented as for cirrhotic portal hypertension predominantly and less for non-cirrhotic portal hypertension. Another question is role of HPPG in predicting variceal bleed. Okay. HPPG, if you are familiar with the concept of HPPG, they say that cutoff they have given for varices to start developing and later subsequently believe is roughly about 10 millimeters of mercury, and they say that beyond 10 millimeters of mercury, if your gradient grows, that varices start developing, and the 12 millimeter of mercury is the cutoff they have given for varices to bleed. And sometimes they even say in the adult literature, if you say if you're HEPG, if you're doing it in a patient who is bleeding and there is a refractory bleeding, HEPG level of more than 18 to 20, if you can measure it at that time, you would find that those patients would not actually respond to your endoscopic therapy. You would require a higher end therapy like TIPS. But this is predominantly adult literature. So HEPG of more than 10 to 12, you can think that patient must have already developed varices and he is likely to bleed. Okay, then there are a couple more questions. Dr. Kunal, should we wait for Dr. Rajiv to join back, or should I continue with the questions?
Yeah, you continue please with the question, because yet there is no signal is coming from Dr. Rajiv whether he is getting connected or not. So you continue with the question and answer, and if you want to elaborate on this further, would be nice.
Okay, let me just look at other questions actually. So the next question is SBP prophylaxis in decompensated cirrhosis in children experienced at your center. We would practically we would give SBP prophylaxis, especially in the older children, adolescents, and the treatment in such patients would be normally to give it for 6 months to 1 year after they have developed their SBP prophylaxis. But preferably, we being a transplant center, we would, once they have developed SPP, for us it is an indication for liver transplantation. We do not beat around the bush. We would tell them that your patient, once he has developed SPP, he requires transplant. So we do not wait for say 6 months, 1 year, 2 years, just to prevent the second attack of SPP. So we would list them for transplant, and simultaneously we would use the fluoroquinolones as they advise in the population. We do use norfloxacin, but we predominantly use them for adolescents only. Dr. Sagar here asked that if a child on beta blocker prophylaxis comes with a UGI bleed, when we start octreotide, should we continue beta blocker or stop it? It's a general consensus that once a patient who has upper GI bleed, for the short term, yes, you should stop beta blockers and start octreotide, because beta blocker, as you know, would prevent the tachycardia, which the children depend on managing their hemodynamic circulation. Even in adults, what they say that you should stop any beta blocker with the patient is continuing, and you can start it say 24 to 48 hours after your bleed you think has settled. So yes, in the initial period, yes, we do stop beta blockers and then we restart it. There is no cutoff time limit which is given, but we usually restart it once we have documented that his hemoglobin is stable and there is no continual bleed. We start 24 to 48 hours later, but there is no timeline for this. Dr. Snehvardhan from Pune asked that is it advisable to investigate children with EHPBO2 for underlying procoagulant status, especially if they do not have? Yes, that's what I'm telling. This practice varies from center to center. We still prefer to do the procoagulation workup since we are sitting in an academic center, we have the luxury of doing it. But does it change your practice? In some manner, yes, because if you find say a genetic procoagulant status, like say for prothrombin mutation you find, or you find a factor 5 mutation, then we would advise those patients that after they have undergone a shunt surgery, whenever they require, they should take a lifelong, ideally a lifelong anticoagulation therapy after they have undergone a shunt surgery. But before shunt surgery, or if we do not require shunt surgery, there is no role unless you are planning to do a shunt surgery, or if you are just managing them with upper GI endoscopies and managing their portal hypertension. There is no requirement practically of procoagulant status, but it is only required when you are deciding whether or not you want to give a lifelong coagulation therapy. Dr. Ankur from Ahmedabad, he is asking, what is the indication of splenectomy in hypersplenism in non-cirrhotic portal hypertension? Non-cirrhotic portal hypertension, you have to think about it in the form of that shunt surgery. Let me be clear, he is asking about non-cirrhotic portal hypertension. That would include both EHPO and NCPF. So let me differentiate both. Splenectomy per se alone would alone in EHPVO, no, definitely no, unless it is combined with a shunt surgery. Second thing, in say in NCPF, non-cirrhotic portal fibrosis, sometimes people have tried shunt surgery, but the results are not as good as EHPVO. But isolated splenectomy, yes, may still be considered in non-cirrhotic portal fibrosis, but ideally we would continue the management in the same lines as EHPVO. We would do a shunt surgery rather than doing an isolated splenectomy. But sometimes you find large collaterals, or you already have a large renal collateral. Then sometimes the surgeons would say that he already had a large renal collateral, so there is no point doing a proximal renal shunt. So in those cases, they just do a splenectomy and they just come out. Okay. Then the question is, especially in children, is it different than adults in view of high risk of opportunistic infections in children? I think Dr. Ankur is asking about post-splenectomy sepsis. Yes, we have to realize that spleen is important, more so in children rather than adults. After splenectomy, the risk of post-splenectomy sepsis lasts lifelong. Some guidelines, some societies, they say that risk is highest in the first 5 years or 10 years. But if you talk to hematologists, if you talk to immunologists, they would tell you that these patients would require lifelong surveillance for sepsis. Spleen is not something that you can just take out and throw away. The risk of sepsis would remain lifelong. So therefore, some guidelines, some societies would continue them on lifelong penicillin prophylaxis. Therefore, it's definitely, unless there is a definite indication, it's a symptomatic hypersplenism, splenectomy alone should not be offered, because you never know that the shunt without shunt surgery should never be offered, because unless you are treating the primary pathology and you do not have any other reason to take out a child's spleen, because spleen is a very important immunological organ, and it would definitely predispose you to lifelong sepsis, even though you have adequately vaccinated them. Vaccination does not always prevent post-splenectomy sepsis. So splenectomy is a major therapeutic decision. Unless, so our point of view is splenectomy alone should never be offered unless you are combining it with shunt surgery, both for mostly preferably for EHPU and as well as for non-cirrhotic portal fibrosis. I'm waiting for another questions. Yes, just give me a minute, please. So that's our colleague from Dr. Tanmay is again from Ahmedabad is asking role of beta blocker in non-cirrhotic portal hypertension. If you look at the Baveno consensus, still nobody is decided as of now whether there is any role of giving beta blockers to prevent primary or secondary variceal bleed in patients like EHPVO or non-cirrhotic portal fibrosis. I've last people in even you ask people in the Western countries like US, they don't give beta blockers. They would rather push them for shunt surgeries rather than giving them beta blockers. So it's a matter of personal choice. We do give them, especially adolescents, but it's not like this the practice of ours or people who are giving it is any evidence based. And seriously, I'm not aware of any evidence. So Baveno consensus for pediatric portal hypertension says there is no definite currently available, as per currently available literature, there is no role of there is no definite proven role of beta blockers in non-cirrhotic portal hypertension. But if you want to give it, if you know how to use the avoid the side effects of all, and if you know it, because predominantly portal hypertension should be managed endoscopically or via shunt surgery in EHPV or non-cirrhotic portal hypertension, do not depend on beta blockers to do the job. The house is still open. I don't think there is any definite answer to that yet. Why transplant is contraindicated in Niemann-Pick type C? Okay. Niemann-Pick type C, unlike Niemann-Pick type A and B, is a different disorder altogether. It's a multi-system disorder in which these patients, if you look at their timeline, majority would present in the initial neonatal period with neonatal cholestasis, and then the cholestasis starts improving, and by end of infancy, first year, second year, there are multiple stages which have been defined, multiple subtypes which have been defined. Then majority would develop neurological involvement. So it is said that sometimes people have transplanted patients in the neonatal period because sometimes they develop a severe neonatal liver failure or decompensated disease in the early infancy, only to find out 1 year, 2 years later when they start developing those typical neurological symptoms, those eye-specific eye movements, loss of upward gaze and all that stuff. Then they realize that they had transplanted a Niemann-Pick type C in the neonatal period, and now they are stuck with patient who is deteriorating neurologically rapidly. And so it is said that unless you are very much sure that this patient is not Niemann-Pick type C, it's usually a contraindication in all liver transplant centers across the world. It's not just Asian centers or Western centers. People do not want to transplant a Niemann-Pick type C because you do not know how early they're going to develop this neurological symptoms. Whether all of them would develop neurological symptoms later, it is still not clear, but majority do develop. People have seen that though it may be delayed, this neurological involvement may come, say, even in the adolescent period. But unless you are in dire states that you have an acute liver failure or a decompensated liver disease, mostly patients, transplant centers across the world would avoid transplanting a patient with Niemann-Pick type C. Is King's prediction rule used in children also, and cutoffs for prophylactic banding in this? Okay. Yes, King's prediction index has been used in children also, especially in biliary atresia population. But as you can see, this is predominantly for choosing when you want to scope a patient or when you want to start. It's not, I don't think it is for prophylactic banding, but it is more when ideally when you should start investigating a patient that he may have a higher risk of high risk varices. A risk of high risk varices when you want to start scoping them, say you will start scoping them, say 6 months of age or 9 months of age or 1 year of age. So these prediction indices help you to choose a patient when you would start doing endoscopy. Dr. Sagar asks, what is your experience with post-liver transplant portal vein thrombosis? How to identify scar tissue collaterals or anastomotic collaterals, management difficulties? Post-transplant liver transplant thrombosis is common, especially in pediatric population, because of multiple factors. Because most of our common etiology is biliary atresia, in which you already have a portal vein atresia and a malformed portal vein, as you can see. So you may develop intraoperative thrombosis, in which the surgeons would have to go in, do reoperate, redo the anastomosis, take out the thrombus, or sometimes they have to use jump grafts. So it's predominantly a surgical domain, especially in the first few days of post-transplant. But after that, sometimes it happens you develop a late onset portal vein thrombosis, say after a couple of days, second week, third week. Then most of these patients then would, after this, would start behaving like your standard EHPV. I should not use the word EHPV because it is a post-transplant setting. So immediate post-transplant is purely a surgical domain. They decide mostly they would go in, reoperate, redo the anastomosis, or put up a jump graft if they do not find a good vein, or later late onset portal vein thrombosis, because they would behave like your standard EHPV, that the portal vein would get thrombosed and they would develop a cavernoma formation. That then you start. Then in any case you cannot do anything in such cases. You have to watch for them to develop varices and all if you require. And some people have even done shunt surgeries in such cases. So Dr. Prateek asks, in respect to EHPV, I believe a patient has genetic mutation that makes hypercoagulable state. The child also has risk of developing thrombosis in other side. So does not that require anticoagulant? Yes. Still, I don't think we have a clear answer on that. So it means that if you have a patient with EHPV, if you can find a genetic mutation, does he have a risk of developing thrombosis other side? I'm not sure anybody has looked into that, but it's still a theoretical possibility. But whether you can give him a long-term anticoagulation therapy just to prevent that risk of anticoagulation, which he may or may not develop. We haven't seen, practically, I haven't seen a patient develop of EHPV or developing thrombosis of a larger vessel at other site. Like practically, I haven't seen, but it's a theoretical possibility. So whether to subject them on this theoretical possibility to lifelong therapy, I'm not sure of that. But yes, if we find a genetic mutation which is proven, then after shunt we would definitely prefer. How often do we find an underlying procoagulant status in an HPOTO? How elaborately do we investigate? HPOTO, the procoagulant mutations are less common as compared to EHPV, definitely. And if you want to evaluate, yes, you should evaluate in the same way like you evaluate any large vessel thrombosis, like you do it in EHPV. So it's less common, but it's still we have the published literature. We have people have found that the percentage varies from as low as 5% to even 40% in some series. In the scenario, if anatomy is non-shuntable, still smashes sphenoidally causing symptomatic hyperthyroidism. Yes, in some cases, ideally shunt surgery, which is proven for EHPV, is Mesorex bypass. But in India, we are only doing proximal sphenoidal shunt. So if your anatomy is non-shuntable, you cannot find any other shunt ways. Still, surgeons still prefer, at least they would go ahead with splenectomy, especially if the patient is causing symptomatic hypersplenism. Definitely, they would go ahead with isolated splenectomy, but it's avoidable. It should be avoided. Any newer treatment modalities in future you people are working on? I don't think we are currently. We are just trying to establish whether we can do REX shunt in EHPV. We still haven't done any. I'm not aware of people doing it in India altogether, but Western literature, they would do a prophylactic Mesorex bypass in the first go when they see a EHPV patient. So I think our future goal is to start doing REX shunts in our EHPV patients. What is the purpose of doing bone marrow biopsy in cases of EHPV hypersplenism? Personally, we won't do it unless, of course, we cannot explain the kind of hypersplenism they are carrying. Because if you look at hypersplenism basically would mean the first thing to go down is platelets, then the TLC, then the hemoglobin. So unless we are expecting a hematological involvement, say if you have very severe anemia which is not proportionate to the thrombocytopenia or say low TLC count, we won't do bone marrow biopsy in EHPO patients. Okay, there is. If a patient is planned for splenectomy and is immunized 2 weeks prior to it, but due to logistic reasons, if the patient fails to undergo splenectomy, it gets delayed another few weeks, do we repeat? I don't think you need to repeat. If you've already given full courses of pneumococcal or meningococcal or Hib vaccine, then I don't think you need to repeat it. You have to give it once, but complete the full course, like using complete the polysaccharide and all the both types of pneumococcal vaccine if you have completed it. Vaccine recommendation when in elective and emergency situation. Okay. In elective, yes, definitely 2 to 4 weeks prior. In emergency situation, I am not sure what is emergency in patient of EHPV or NCPV. It's very less likely. We haven't had any emergency situation of in this regard. So better to avoid any emergency in such situations. I don't think there would be any emergency in planning a shunt surgery in EHPV and NCPV, especially if you're following them up. If you're saying a shunt surgery for a refractive varicose bleed, that is very, very less likely scenario. And I don't think I can find any other questions here. Dr. Kunal, I don't think we have any more questions here. Should we wait for Dr. Rajiv to join back?
Yeah, Dr. Vikrant, the question, if it's got over, I request you on the pediatric portal hypertension, you give the concluding remark, right, on the presentation by Dr. Rajiv and the questions asked by the participants, and we will conclude the session.
Are you able to contact Rajiv sir for that?
Yeah, we have tried. It is not possible to get him on this presentation. Okay. So requesting you to give summarize the pediatric portal hypertension, what Dr. Rajiv has presented, and the summarize and give the take-home message to the participants on the questions they have asked.
Thank you all for joining in this session of this. Unfortunately, Dr. Rajiv could not, there is some technical glitch and he could not give the take-home messages on his own, and like how he explained the different case scenarios on how to differentiate, especially between cirrhotic and non-cirrhotic portal hypertension, because that's the first and most common differentiating feature that we should try and do it in every of our portal hypertension patient. And I think it's because these kind of disorders, EHPVO and cirrhotic portal hypertension or even non-cirrhotic portal hypertension, are very commonly seen. EHPVOs, I think Indian subcontinent has the highest experience of managing such cases, and these things would keep on cropping up. So I would request every person, whether they are linked to pediatric gastroenterology or hepatology practice or not, it's better that you diagnose these cases. If at least you can do is, if you can think of whether it is cirrhotic or a non-cirrhotic portal hypertension with the kind of data Dr. Rajiv presented with the clinical, if you can clinically differentiate them, put in your papers, start the basic investigation, and if it's better that you can refer to a gastroenterologist or hepatologist. That's the best part, a person who is doing primary practice at all. And I think I got a message that there was a technical glitch from the administrative side, and sirs Dr. Rajiv could not get logged in even after disconnection. There was a technical glitch, and I think maybe it's time. I think we can wrap it up. It's already more than an hour now. I thank Dr. Kunal and his team and Panisha Biotech for giving us this opportunity. And I think we will see you in the next session on this series and webinar. Thank you so much.
On behalf of Panisha Biotech, we thank Dr. Rajiv Khanna and Dr. Vikrant Sood. The topic was really most important, and we have seen that during last time presentations from the eminent faculties like Dr. Rajiv Khanna and Vikrant Sood from Ireland BS. We have got a tremendous response, and participants were there and they were asking for the next session. We are extremely sorry for the technical errors which were not beyond our control, and we tried to resolve it. As you have seen that there was a little delay in starting the session, and in between Dr. Rajiv was not able to connect, and this is sometimes happening. And as the technology is advancing, and not only India but globe is experiencing the virtual world interaction, coming days we will be more perfect and with the zero error. Dr. Vikrant has really taken up all questions, and their unit, yes, is very important for the newer treatment modalities, and what they are going to do in the future and developing the guidelines is most important concern for Indian doctors, those who are managing pediatric portal hypertension. And ILBS as a tertiary care center and academic center, and Dr. Rajiv and Dr. Vikrant both are available with you always, all the time. And Panisha Biotech is providing this platform for your academic interest. And be there, be together from the makers of Silamin and Livolec for the portal hypertension and Livolec fiber for the constipation. We will keep on meeting and managing this academic platform to the all delegates, and we will keep you informed. Thank you very much for participating for this webinar on behalf of Panisha Biotech, and have a nice evening. Thank you very much. And we are closing this session.